Thank you, Dr. Meena, for this kind invitation and the lovely introduction. Our brief was very clear for the Chief. He said practical points, and we'll stick to that. So toning down the mature and black cataracts. Now, these are hard cataracts. We need to use a soft shell technique. Dispersive coats the endothelium and cohesive creates space. Use it judiciously because it blocks the tip also, so you need to take out some part of it. Otherwise, you could have a wound burn. A capsular excess needs to be of good size if it's a hard cataract. Too small could cause capsular block and you could have issues. If it's a hypermature cataract, you'd like to keep your capsular excess small so that you control it and there's no runoff. And if it's a otherwise brownish cataract where you can see a good glow, or you can have a rather large capsular excess, or you can go in for a secondary enlargement of the capsular excess. Hydrodissection, you need to be very careful about the capsular block and the PC blowout. Use very small amounts, decompress very gently. Now, you see this, you'll see that nucleus move up anteriorly. Every time you hydrodissect, it moves up anteriorly and that capsular excess enlarges, and you need to decompress with every alicot that you use. And the space is very limited, so you need to go very cautiously. Now, this is indiscriminate hydrodissection. Watch this very closely. I'm not decompressing at all. And I keep injecting. I don't know what came upon me, and I was probably more mindful about the hardness of the cataract. And then we go ahead with the phaco, and as we go ahead, we keep this, watching this, and that was my heart. So we need to use high vacuum pulse phaco. Beginner would probably prefer diagonal chop. You could go for a vertical chop, which is a variation. Diagonal is only a variation. Now let's look at vertical chop. Basically what we are trying to do is we need a spike-like chopper. A Chang chopper is preferable. We need to hold the nucleus with the phaco probe, lift it up, and the vertical chopper goes down. And now how far your chopper is from the phaco probe decides whether it's going to be a direct vertical chop or a diagonal chop. Now this is a near diagonal chop. You create a small trench, and that allows you to hold the endonucleus firmly. And I hold that endonucleus, and I'm going to pull it up a little bit, and then I use that sharp chopper, and I go down towards the phaco probe. And there is a give, and that whole chop extends to the posterior plate, and that cracks into two, and you'll be able to see that red reflex. At this stage, it's better to probably have you could probably keep chopping also, but it's better to have the two heminuclei completely separate. It adds to your confidence and makes you feel a lot comfortable. So again, rotate it 180 degrees and again come back, and this part is easier, but you need the chop to go all the way to the posterior plate. Otherwise, it's not a successful chop, and you'll have a messy situation with those sticky fibers over there holding on to the fragments. Now, after this, you need to go to the meat of it, so it's better to lollipop it. You need not go from the surface of the cataract. You can go from the side of the heminucleus, and that gives you a better lollipopping effect, and you get a better firmer grip, and you can see, and it allows you more space. Now, for beginners, you may actually not believe that the chopping is so easy. So a better way is to move a bit cautiously, probably. So you can keep scratching it, of course, with a considerable amount of force. If you keep just scratching, you'll be there all day and you won't progress any further. You hold that nucleus, and you will have a loss of hold over it, and you can re-grasp it and keep going. This is a very hard cataract. With a little bit of patience, re-grasping. Though scratching is not the right way, but that would probably give you the con. And once you manage to crack it like that with a vertical chop, you will never ever let go that vertical chop. Once you have had that feeling of that give, you know that yes, every hard cataract can be chopped. So that's the way. And you can turn around and go, and you need to again go deep. I prefer to, when it's a very hard cataract, I prefer to have the two heminuclei completely separate and then go ahead and chop it into. You see, this is specially tailored for beginners, so more experienced people will probably go for the direct vertical chop. And once you have the two heminuclei, do not push the two heminuclei too far side, because your space in the bag is limited, and go and work in the depth of that groove, that crack that you have created. Like I said, the point of attack is use the thickness of the nucleus to lollipop, and you go from this side of the heminucleus, and then you chop, and that makes it a lot easier because you have enough space for the phaco probe to travel. The beginner it's not the technique, it's actually more that you're scared of probably doing collateral damage, and these things are taken care of by these small tips. You may support the nucleus with the chopper as the phaco tip advances. It never really actually moves the bag so much, but that's just that fear that you have. So you support the nucleus with the phaco tip, and that takes care of that. And of course, like I said, you need to separate those. You need the chop to go all the way down to the posterior plate. Otherwise, life is going to become very difficult when you start dealing with those fragments. Now, that is again dealing with you need to have these fragments as small as possible inside the bag. That is your most comfortable area, because once you get these pieces into the it's very difficult to get them through that rhexis. You may damage that rhexis. You may cause, if you keep that rhexis intact, you may probably damage the zonules. So you need to get those fragments as small as possible, so the next step becomes easier. And because invariably for beginners, you'll be probably coming more into the iris plane and anteriorly, so you will be causing more collateral damage because of the endothelial damage caused by the use of ultrasound power closer to the endothelium. So it's best to finish off all the chopping and all the fragmentation inside the bag. That is the safest place, and you never actually damage the bag while chopping. Invariably, the posterior capsule actually ruptures in the last fragment, and that is when you need to be extra careful. What I would suggest for beginners, because for a vertical chop, you will be using a large chopper with a sharp spike. You could probably exchange this for a smaller chopper as you're dealing with the quadrants or with the second instrument, because you just need to toy around with these fragments as you emulsify them and remove them. And it's a good idea to keep topping up viscoelastic, put lots on the cornea, on either side of the cornea, so that eases your nerves. You see, it may be absolutely superfluous, but you just keep doing that. It doesn't, methyl cellulose doesn't cause a great deal, so you can keep doing that. It helps you take a deep breath once in a while and regain your composure, because these require a lot of patience, and it does really call a tax on your nerves a bit. So, especially in the, how experienced you are, it really doesn't matter. Every difficult case really calls for a gush of adrenaline. So, you need to breathe easy, and like I said, for the last fragment, you change over from the chopper to the spatula, reduce your vacuum and flow, use a hyperpulse or micropulse or slow motion phaco. You reduce your parameters by at least 25%, so that you do not have a post-occlusion surge. Nowadays the machines are fine, very good, everything, but if you keep topping up a bit of viscoelastic, the possibility of any surge is actually reduced. So you do that, and you can go slow. Once you go slow and you have control that foot pedal with your foot, you are in absolute control of the situation. And this is the place actually invariably where you have a PC rent, because you tad bit lack of concentration you have. Now, use of CTR, it's always preferable to use a CTR probably towards the end when your bag is actually empty, when you've created space for the there is a publication which suggests that the CTR used early causes more torque. This was a small people had no way of knowing that this was initially selected for the challenging cases in ESCRS 3-4 years back. And this, I had no way of knowing that this lens was subluxated and I had loose zonules over there, but halfway through I realized. Now, I was not putting a CTR as yet because I did not know whether I'll be able to pull it off. So I used the heminucleus as a temporary capsular retention segment, and I rotated towards the direction of the subluxation. And then I used that CTR to support my bag. And see, because if I was not sure, but if I put that heminucleus on that side, then I would get an idea of how strong the rest of the zonules were. So once I was convinced that my zonules on this side were strong, then I could put a CTR, and then the rest of the case was rather simple. And once that CTR is in place, now lax capsule. This is another problem with these big bags. They're huge. You just watch this case. This was a hard cataract, and look at that. Look at that. Every time I go for that cortical wisps, that whole bag comes into that aspiration port. And every time I go and inject viscoelastic, the bag again inflates like a balloon, all the way, as if nothing was amiss. And there you are again. And this cat and mouse game goes on for a long time. I can't put in a CTR at this stage because though that will make my cortical aspiration difficult, because these are again fibers running all the way till the equator, and that would get trapped in the CTR. So I had to deal with this very patiently, and then eventually I did, because this particular bag is going to contract and my lens is going to be decentered. So I would rather put in a CTR and have that bag expanded well enough before I put in that lens. That way I would be ensuring that even if this capsular bag contracts it to some extent, my lens will be totally centered throughout. Now moving on from this I think is probably the last of the, yes, we will go on to the white cataracts. Now I've classified them into 3 types. You have the off-white types, little dirty white types, which are actually not very intumescent, and you can control your capsular access. You really need not worry. you can put all sorts of viscoelastics and trypan blue, and you can keep re-injecting your viscoelastic, and this will not run off. This will not really run off to the periphery. You can control it. There is hardly any milky fluid over here, so you can control it and make your size. You can keep doing whatever you want. There's a second type, which is the milky white type. That's the milk bag. You see? And this is a typical milk bag. So, and you will see how late till the capsular excess the milk kept coming out. So this is viscoelastic under cohesive viscoelastic. And I just make a nick initially, and I keep topping up the viscoelastic so that bag just cannot allow that fluid to just come out immediately, which would lead to an Argentinian flag sign. Sometimes you are lucky and sometimes you are unlucky. Then I inject viscoelastic and try to aspirate, because I know this bag is really huge and it's full of that milky liquidy cortex. And I just can't initiate my capsular excess. Every time I put in viscoelastic, some more milky fluid keeps coming out. Then eventually I start initiate. And in these cases, even if you're a needle guy, I'm a totally needle guy for capsular excess. But in these are the case situations where I always use a forceps. And I am here now injecting viscoelastic on one hand and using a capsular excess forceps on the other hand to complete that. And as I said, I like to keep this capsular excess small and controlled. I won't mind doing a secondary one. These are chalky white ones are the ones where you have a fibrous capsule. This was selected in the academy this year and as a challenging case, and the ACRS as a challenging case. Now, this is patchy staining. It's plastered. The anterior capsule is just plastered to the cortex. I just cannot initiate a capsular excess. I am struggling, and try whatever. I tried everything in the trick in my bag. I pulled out every possible trick. I tried the needle. I tried the capsular excess forceps. So look at that. When I pull on it, the zonules seem to be threatened. So now somehow it's like wet blotting paper. I touch a side and it just kind of the bit comes off. So I was really at a loss. I just felt like if somebody else could take over, I'd be very happy. But then I do manage to have a little bit of success over here with the capsular excess, but sooner than later it starts running away to the periphery and I have to control it. And thanks to Brian Little's technique, and I just kind of managed to get that inside. And look at that. That non-staining area was because of that subcapsular fibrosis and adhesion. And then this was a decentered small capsular excess in a hard cataract. I really knew that it was going to be difficult. So I started nibbling over here, and eventually this is what I had. But the advantage was this capsule was fibrous, so I didn't have a runoff of those jagged edges, and that would be it. Thank you very much for your kind attention.